very pleased to participate in this osteoporosis meeting. And I thank you also all the colleagues of Ukraine that I hope that they are as well as possible, and all of them may be safe. So God allow it. And I also want to thank you this invitation to our colleague Natalia Grigorieva. And so I am presenting the endocrine osteoporosis. Endocrine osteoporosis is very common and is one of the main causes of secondary osteoporosis. Here you have the Cushing syndrome, hypogonadism, hyperthyroidism, vitamin D deficiencies, hyperparathyroidism, type 1 and type 2 diabetes, anorexia nervosa, and acromegalia are very usual causes of endocrine osteoporosis. And also some medications such as glucocorticoids, analogous, LH-ARH analogous, and anti-estrogens and androgens that together are several times used in breast and in prostate cancer, are also able to develop osteoporosis and fractures. So regarding the thyroid, we have the hyperthyroidism, which is typical to originate osteoporosis, and by C3 and C4. C3 acts in osteoblasts and in osteoclasts, and C4 stimulates directly or indirectly the activity of osteoclasts. TSH, this pituitary hormone that regulates the thyroid, has a direct negative regulator effect on bone remodeling and inhibits both formation, differentiation, survival of osteoclasts, and the differentiation of osteoblasts. So, in hyperthyroidism, there is a lot of signs, as you can see here, but there is also an increased mortality by cardiac, by heart disease, and also by osteoporosis and fractures. So hypercalcemia is present in some patients, and there is also a negative causal imbalance in hyperthyroidism with a secondary high calcium excretion and suppression, which leads to suppression PTH and low calcium, free calcium in these patients, and there is also a low PTH, vitamin D, intestinal calcium resorption, which leads to hypercalcemia, which results from higher bone resorption. So we have made some studies, and we have here the results. The studies in hyperthyroid elderly women. We have here the prevalence of normal BMD, low bone mass, and osteoporosis. And as you can see, almost more than 95% of these women has low bone BMD or osteoporosis, but more than 80% of these elderly women has osteoporosis associated with hyperthyroidism. And regarding a group of men that we have, that our group have also compared to a control group, as you can see, there was a reduced and osteoporosis was very prevalent as compared to the control group. So regarding the type of therapy of these diseases, we have radioactive iodine and also surgery or anti-thyroid drugs. And the radioactive treatment is associated with higher osteoporotic fracture risk and with higher precocious death risk. But surgery and anti-thyroid drugs are associated with low osteoporotic fracture risks. So, and the treatment of hyperthyroidism usually leads to an increase of BMD and a decrease of osteoporotic fracture risks. So regarding other factors to the bone health, we have here the androgens and the estrogens. The estrogens and the androgens have an action on osteoclastic activity by blocking them, And the estrogens also increase the osteoclast apoptosis, and the androgens block also the osteoblast apoptosis and increase the osteoblast proliferation and differentiations. So it gives origin to bone growth, increased bone growth, increased bone maturation, and also bone maintenance. And here you have the mechanism of bone loss at menopause, which are described in every manual. And as you can see, the ovarian failure leads to decreased estrogens, and this decreased estrogens leads to a bone loss and increased bone resorption and increased osteoporotic fatigue. And here you have the several mechanisms which also leads to this increased bone resorption and bone loss after the menopause, above all after more than 5 years after the menopause. So regarding the men, the testicular dysfunctions leads to hypogonadism by decreasing the testosterone and or sperm production. There is several causes for my hypogonadism by direct testis diseases or by hypogonadism, secondary hypogonadisms. And we have the list of those diseases, and also some drugs also affect the male testicular function. So here you have some results of studies that we have performed, and you can see in 33 men with hypogonadism, more than 65% of these men had a low BMD or even osteoporosis, almost 40% of them with osteoporosis. So, and regarding elderly men with andropause, let's say like that, there is a reduced BMD and a rapid bone loss if there is a decreased estrogens and a decrease of sex hormone binding globulin. And there is this bone loss is most rapid when there is also a decrease of the androgen levels, like testosterone. So, there was some reports regarding the aromatase gene mutations and estrogen receptor mutations, which also leads to bone loss and osteoporosis. So in hypogonadism, you can see there is a decrease of BMD in lumbar spine, at the hip, at the radius and the whole body, but the TBS at the lumbar spine, as you can see, was lower, significantly lower in men with hypogonadism as compared with the control group. So, and the effect of androgen therapy on the BMD, it increased the BMD. It is age independent, and usually this increase is higher in the first 6 months of the treatment. But fracture data are not yet available, and thus the long-term benefits of testosterone requires also further investigation, above all in the elderly men. So regarding the hypercortisolism, which is it is the result of pathological states of glucocorticoids excess. We have the pituitary-dependent Cushing syndrome and also the ACTH-independent adrenal Cushing syndrome. And most of the case due to exogenous administration of glucocorticoids. So here we have what happens in this case. There is the hypercortisolism leads to decreased bone formation and also to increased bone resorption by several mechanisms, by hypogonadism, as you can see, regarding to bone receptor in osteoclast, and also by reducing the bone formation in osteoblasts and the osteoblastic function. By the other way, there is also a decreased calcium absorption in the gastrointestinal tube, and it leads to an increase of PTH, which also leads to an increase of bone resorption. And all this together leads to osteoporosis, and of course, with age also with to bone fractures. But the endogenous Cushing's, the endogenous Cushing syndromes, there is scarcity studies because it's not so frequent. The fracture sites are dorsal, lumbar, hips, and pelvis. There are several studies revealing spontaneous fractures with minimal energy impact trauma. And trabecular bone mass is not related to hypercortisolism degree. After therapy by surgical means, there is bone formation markers are elevated some days after treatment, which reaching a maximum at 6 months, and there is also a progressive increase of the BMD, as you can see here. So, and regarding the obesity, is obesity a risk factor for osteoporosis? There is a bone fragility associated with obesity or insulin resistance syndromes. Why? So we know that the adipocytes and the osteoblasts have the same origin, as you see from the mesenchymal stem cells. They give origin to osteoblasts, and also they give origin to adipocytes. And in obesity and also in diabetes to obese people, you can see there is an increase of this PPAR gamma, which leads to increase of number of the adipocytes and a decreased number of osteoblasts. So you can see there is that's one explanation for this association. And we know also that there is an osteocalcin secretion by the osteoblasts, which also leads to fat accumulation, insulin resistance, and diabetes type 2, and also to atherosclerosis and cardiovascular diseases. So we know that obesity and excess fat mass are risk factors for low BMD and fragility factors. Trabecular bone score in these, or TBS, in these people are inversely related to BMI, bone mass index, and decreased BMI leads to a negative impact on bone quality. We know for recent studies that this ratio, lumbar spine BMD by the BMI and TBS is increased. The association between increased BMI and increased BMD, and there is a decreased TBS in the obese people, and the lumbar spine BMD and BMI ratio was more correlated with TBS than lumbar spine BMD. So regarding diabetes mellitus, it is a very prevalent disease, above all the type 2. We know that hyperglycemia leads to increased urine calcium loss in both type 1 and type 2 diabetes. Type 1 is more frequent in people aged less than 30 years, and we know that bone turnover is usually low in these people, and in long-standing diabetes type 1, there is vascular lesions which leads to low bone mass and increased risk of fractures. So we know also that there is an increased risk of hip fracture in diabetes type 1 persons, but in type 2 there is just an increased risk of fractures, and insulin has an anabolic effect on bone, But for type 2 diabetes, there are different effects of fracture risks with reduction with metformin and increase with thiazolidinones. And of course, the complications of diabetes can also increase the risk factors by effects on bone, by metabolic effects, or by association with an increased risk of falling. So it is also known that the diabetes type 2 was associated with higher BMD at all sites, but with a lower TBS, the trabecular bone score, revealing so that an increase the risk for osteoporotic fractures. So here you have the most frequent skeletal regions of fractures in people with diabetes and also with obesity: at the hip, at the foot, upper arm, ankle, spine, and forearms. As you can see, this is a little bit different from the usual fractures in people without these diseases, diabetes or obesity. So we have already spoken about the effect of PMD of some drugs. So again, sulfonylurea may lead to a negative effect by hypoglycemia, and the others usually have a positive effect, as we have already seen. So here you have the abnormal skeletal properties with reduced turnover in these people with diabetes. There is abnormal biomechanics with worse skeletal geometry, increased cortical porosity and associated with fractures. There is also a reduced bone quality. There are a lot of falls in these people with above all by hypoglycemia. And also some drugs can affect these people. So regarding now the hyperthyroidism, we know that the parathyroid has an action in resorption, in the bone resorption. It increases at the kidney, it increases the vitamin D production, the calcium resorption, and also decreases phosphate resorption. And at the gut, it increases the calcium resorption. And as you can see here, so the increase of bone resorption leads to cortical bone loss and to fractures. And hyperparathyroidism is the main cause of hypercalcemia. So we also know that people with people with diseases can have surgical indication when the BMD is with a test score lower than 2.5 standard deviation at any site, or if the patient is younger than 50 years old. And after surgery, what happens? There is a fracture rate similar to control, and without fracture risk different from control. So let's see what happens in acromegaly. Acromegaly is usually due to pituitary adenomas overproducing growth hormone, which causes this disease. And this disease induces bone enlargement, particularly in the extremities. Bone cells are a target for a growth hormone and for its mediator, insulin-like growth factor, IGF-1, which mainly act on osteoblasts and also on osteoclasts. In osteoblasts, inducing their differentiation and enhancing their function. In osteoclasts, there is less extensive action of IGF-1 So we know that acromegaly at trabecular bone originates a deterioration in the trabecular microstructure of the radius. In the cortical bone, there is an increased porosity and reduced cortical strength. And in bone turnover, there is an enhanced bone formation induced by growth hormone and IGF-1 excess. So, but there is also an increased risk of fracture, up to 8-fold increased rate of osteoporotic fractures in these people. And the TBS is also lower in men and as well as in women, and the treatment increased BMD but decreased TBS by 3%. So here you have finally, you have resume of these disorders. You have the obesity, type 2 diabetes, and so on. And we have the most increased risk with acromegaly, diabetes type 1, overt hypercortisolism, and also with hypogonadism, and the higher risk of hip fractures is of type 1 diabetes and also with hypogonadism. And the TBS is reduced in all of these type of these diseases, as well as in hyperthyroidism, because our group have shown that the TBS is reduced in men and in women with hyperthyroidism. So, it is just to stress that also that endocrinopathies are very well related to bone loss and to bone fractures. We must also look for these type of events in people with endocrine diseases, and I want to wish to all our Ukrainian colleagues all the best for them and all their families, and that the wars will end very soon, and that you will win this war. Slava Ukraina!